How's that for volume? Can everyone hear okay? Okay. Good morning, everyone. Am I the only one who brought their entire family today? Your families had a little more confidence you would complete the program, or what? My name is Kirsten McLaughlin. I completed my final practicum with the BC Centre for Disease Control in their harm reduction portfolio. And my final project was design of a take-home naloxone pilot program run out of the emergency department in Kamloops, where I also work as a staff nurse. So to begin, we need to frame the issue of opioids and public health. So opioid misuse and addiction and the subsequent morbidity and mortality associated with it is a growing and global public health concern. Here in Canada, we have the highest prescription opioid rate in the world, and provincially, we're in the midst of a fentanyl crisis. Luckily, there is an antidote to opioids, a medication called naloxone, which is also known as Narcan. Naloxone is safe, it's inexpensive, it can be given via a variety of routes, and it's been on the World Health Organization list of essential medications for over 40 years. From a public health perspective, I think it's really important to acknowledge that the morbidity and mortality associated with opioid overdose exacts an inequitable and disparate toll on some of society's most marginalized. So that includes the poor, racialized, and ethnic minorities, as well as individuals who find themselves cycling in and out of the criminal justice system. So what is take-home naloxone? Take-home naloxone is really the marriage of opioid overdose education with the provision of a naloxone kit, which you can see here. So what we know from research done in community is that take-home naloxone kits do reduce the mortality and morbidity associated with opioid overdose and do not result in increased opioid use, pose a danger to opioid users or those peripheral to them, or fail to motivate a behavioral change. So what we would typically think of as abstinence, entrance into a detoxification or treatment program. So with that in mind, in March of 2014, the BC CDC and Interior Health Authority launched Canada's first take-home naloxone program out of an emergency department in Kamloops. And after a year of operation, we had dispensed 36 kits and had 3 known overdose reversals. So we decided it was time to evaluate the program. So our evaluation questions really focused on facilitators and barriers to implementation and success of the program, as well as provider attitudes and knowledge base around take-home naloxone and opioid overdose. Kamloops was an interesting place to have this program launch. It might be more intuitive to think that perhaps it would be St. Paul's and Vancouver or other sites where perhaps we would more typically think of opioid overdose as a greater issue. And so really we're trying to look at, the questions are sort of aimed to get at why Kamloops in a lot of ways. So study design is mixed methods, but certainly heavily weighted towards qualitative inquiry. So our evaluation team members are the BC CDC harm reduction team who are really taking the lead. Myself, some of our UBC family medicine residents working out of Kamloops, and the Interior Health Authority. The study site is Kamloops Royal Inland Hospital Emergency Department. And our participant sampling and recruitment, our sampling strategy is really, it's purposive and homogeneous. We're looking at registered nurses and physicians in the Royal Inland Hospital Emergency Department, which essentially is our inclusion-exclusion criteria. From a sample size perspective, we have 14 physicians and 102 RNs, so we're not looking at a huge sample size, and therefore we'll be emphasizing depth and richness of data as opposed to breadth. We will recruit study participants via email. We'll send out an email to the entire department sort of outlining the evaluations, its aims, and how people can participate, and we will not be focusing on retention. So what tools did we choose? Why did we choose them? How will we use them? So self-administered survey questionnaires, pretty familiar to most. You can reach large audiences, relatively low cost. And ours was designed based on the theory of planned behavior. So we could sort of look at which behaviors registered nurses and physicians undertake and why, if we can sort of get at that. Interestingly, each piece is designed to inform the next piece. So once self-administered survey questionnaires are finished, some quick data analysis will be used to help inform interview questions and then focus groups from there. In-depth interviews yield rich data, give you the opportunity to explore topics in greater depth, though they can be costly and time-consuming, so we have limited the interviews to key informants only, so individuals who are quite close to the program. Lastly, focus groups, again, yield rich qualitative data via conversation and interaction, and we'll invite staff members to sign up. And we'll have distinctly registered nurse and physician focus groups that will be separate. So our setting is the Royal Inland Hospital for all of these questionnaires, surveys, interviews, and focus groups. The incentive is really communication of findings back to participants, and our timeline is about 3 to 4 months, dissemination excluded, and we will do that over the course of this summer. So data analysis procedures, data will be managed in accordance with Tri-Council Policy Statement 2 standards. The large research team will get together and develop codes, and hopefully themes will develop from there. All research team members will be asked to undertake some form of memo writing of analytic decisions, so we have sort of an audit trail of what's gone on. Again, design limitations with sample size. Because it's a mixed method study, we're not looking for generalizability, but perhaps some transferability of findings to other settings. And we'll also be using different forms of rigor in striving, or pardon me, different forms of triangulation and striving for rigor. So data triangulation, methodological, observer, etc. So interviewer skill is also perhaps a bit of an issue. We are using our UBC Med residents to conduct the interviews, and they may be new to this, but through debriefing with the larger research team, we're hoping that they develop these skills as they go, and if there's any concerns, we can address them early on. Ethical issues. So confidentiality and privacy really tie in with the informed consent. Certainly the research team can provide assurance of confidentiality around interviews. Focus groups are a little different because you do have other people involved, so that will just need to be explicitly stated. There is the issue of coercion and deformed consent, considering that I am a nurse in the department and perhaps people will feel the need to participate, or that, you know, that I would really encourage that. So in sort of mitigating that, I'm absenting myself from the data collection process, but hope to find a role in analysis. And we have gone through the appropriate research ethics boards for this study, so that included Interior Health, UBC, and PHSA. Findings, distribution, and use will be tailored to this, well, we're not tailoring the findings, but how we will develop them and send them out will be different. That'd be nice, but, you know. So Interior Health will probably do a one-pager for staff who've taken part. BC CDC and stakeholders will have the larger, more detailed research findings, and then the hope is to publish in a journal. So strengths and challenges. So the literature review for this was a bit of a rabbit hole, if you will. Seeing as this emergency department, it's the first in Canada to do this, and the second that we're aware of in North America, there isn't a lot to be found in the academic peer-reviewed literature, which interestingly also became the strength of the project. We found that when connecting with journal editors, following up with people in the States, the harm reduction community is really eager and willing to come forward with, here's our policies and procedures, here's our toolkits, here's what we're doing. And so we've kind of created this interesting network that I think has turned out to be a real strength of the project. So in the short time frame, the idea of, so what's the take-home message, the so what of all of this? And I think I found this quote, and I think it summarizes it so well that I don't have to make it up for myself. So while research that further establishes the efficacy of naloxone may assist in expanding its distribution, the research and public policy agenda should not be defined primarily by objections that undervalue the lives of individuals who use opiates. So my sincere thanks to the following: Dr. Buxton, who was my preceptor, Ashraf Amlani of the BC CDC, the whole BC CDC harm reduction team, Dr. Catherine Worthington, Victoria Barr, and my fellow MPH students and colleagues. Don't be nervous, it's not that bad up here. There we go, thank you.
All right, so Kristen set us up in fine form. She did it in about 9 minutes. See, perfect timing. She breathed, everything's good, she's still alive. Yep. So we definitely have time for questions. And I know, I mean, again, these 10-minute snippets of 450 hours plus of work are not really enough to describe it all. So I'm sure there are questions. Who wants to start? Oh. I'm going to go to this corner first, Lynn. Griffin's got a question.
Great presentation, Kristen.
Thanks,
my question isn't necessarily around the evaluation, but more around You know, my involvement with this program within my own position is around providing the naloxone and the training in about 10 to 15 minutes in an individual interaction. I wonder how you guys have achieved that within an emergency department where obviously time is of the essence and there's so much going on.
That's a great question. We typically do our training with participants in 5 to 10 minutes, realistically, in the emergency department setting. And I think that's been a big barrier to implementing this in emergency departments, was that fear. So I do have a great article for you on retention of this information a year out after only 5 minutes, and it showed that participants did retain the information. But as well, one of our criteria for kit dispensation is that an individual presents to the emergency department because of an overdose event. So for us, the clientele that we have targeted with this tend to be fairly familiar with needles, and so the teaching can be sort of condensed a bit. And we do have partnership within the community with a number of community sites who individuals can then follow up there if the training isn't sufficient in the emergency department setting. But so far, things have looked good. But again, I can't tailor my findings, so you're welcome.
And Lynn has a question.
I want to compliment you on your wonderful grasp of program evaluation, especially considering that we haven't figured out yet a way to jam that into the MPH curriculum. And I also want to tease you a bit and just ask you, what's wrong with tailoring your findings?
I find that people question it. Yeah, it's a credibility thing. I don't know.
That was the right answer. We have time for one more quick question, if there are any. Oh, yes, perfect. Thank you, Michael.
Great presentation. My question is around how you went about tracking the use of the take-home kits.
Sure, so we have in the emergency department, all our medications come out of a machine called a Pyxis machine. If any of you have ever watched Nurse Jackie, that's kind of the idea. So it tells you in the machine who the physician is prescribing, who the nurse is, who took it out. And so all the kits have a tracking number, so we can track that an individual picked up a kit in Emerge, had it refilled at this community site. It's all set up through the BC CDC, so we were lucky to just be able to sort of plug our sort of modified model into that, and it seems to have worked out quite well. Okay, thank you, everybody.
Yes, thank you. Thank you, Kristen. Emily, come on up.